Welcome to our Caribbean and African Targeted Health Improvement Program, CATHIP Health Hour. The Caribbean and African Health Network, CAHN, along with its national partners, are incredibly pleased to continue to bring to you targeted health and well-being education delivered by Caribbean and African doctors. These health hours are all about empowering, educating, and giving space to Black people so our communities can look after themselves better. Every Saturday, our Black GPs or consultants present on those health and well-being topics that affect you, your family members, and friends. Some weeks will vary and will include other panel members such as pharmacists, specialist nurses, and faith leaders. Our health hours cover a range of topics and include mental health, heart health, women's health, reproductive and sexual health issues, men's health, respiratory problems, cancer, sickle cell, and many more. We have not forgotten to include within our health hours the many societal, cultural, religious, and racial challenges that can go hand in hand with health problems and influence how we should respond to meet health and well-being needs. The sessions are designed for you, and we want you to use the time to listen, learn, share your experiences, and ask questions to our Black doctors. During every session, we will gather your feedback so we can continue to respond to the needs of our Black community. To request any particular topic, please email health@cahn.org.uk. We encourage you to invite others to our health hour sessions. Spread the word in our community. CATHIP is funded by the National Lottery Community Fund.
Hello, good morning, everybody. It's a lovely Saturday morning, and we thank God for such a good day so far. You're all welcome to this morning's CATHIP Health Hour session. It's Saturday, the 17th of December, 2022, and who would believe that we're almost at the end of the year? My name is Dr. Diana Asante, your regular host for this program, and it's always a pleasure and an honor to be hosting you on these Saturday morning sessions, where we bring you topics that would enrich your knowledge in your health and help you to be able to manage better, but also be educated and equipped to take better control of your health. And we also do have the privilege of having our own Black seasoned consultants or GPs or clinicians week in, week out to volunteer their time to teach us, to empower us, and to have these discussions with them. So once again, welcome to the CATHIP Health Hour session today, wherever you're joining us from, whether you're on Zoom or YouTube or Facebook, or following us on our Twitter, Instagram pages. We really appreciate your time, and we would love to enjoy the sort of next hour and a bit with you this morning. So we've got a very important topic, one that we've probably had quite a few times, but due to the importance of the topic and the fact that it's so relevant, we've decided to sort of end the year with it, if you like. This will be our last health hour session for this year, 2022. So today we'll be talking about hypertension and your heart. How should you care? And I know we've talked about hypertension even on the health hour several times and on different fora, but we know that still a lot of hypertension is going undiagnosed, and we know that it's still prevalent among our community, people from our ethnicity. And we also know that unfortunately people are still having complications from hypertension, for example, heart disease or even strokes. And some people may have queries about their medications, or people are not always so compliant. And so we've decided to just tackle this topic one more time. Today, we've got a wonderful GP who's got a special interest in cardiology. His name is Dr. Quincy Chuka, very experienced clinician who spared his time this morning to be with us. And so join us as we invite Dr. Quincy Chuka to take us through the session. As usual, there will be a Q&A session after he's given his presentation, and let's make this session as interactive as possible. When we get to the Q&A, unmute if you can to ask your questions, giving your contributions, and let's make this last session of the year a really memorable one. Over to you, Dr. Quincy Chuka, and thank you so much for your time. Lovely to have you on the CATHIP Health Hour this morning.
Thank you. Thank you, Diana. Good morning, everyone. I'm going to share my slide. Can you all see my slide?
Not yet.
Okay, so
Yes, we can.
excellent. So, okay, excellent. So, good morning, everyone.
Good morning.
Thank you all. Thank you, Diane, and thanks to Charles for sending me a message first thing in the morning, early morning, and waking me up and asking me, can I do this talk? So I said, yes. So this morning I'll be talking to you about hypertension and your heart and whether you should or you should not care. Who am I? As Diana said, I'm a GP with special interest in cardiology. I'm a partner at a surgery in Warrington. I train other GPs. I'm also the cardiovascular lead for Warrington CCG or place or whatever it's called now. And I'm also the chair and chief medical officer for our GP Federation in Warrington. So when Charles asked me to speak, hypertension, it's something that I'm passionate about, and I've been working with practices and pharmacists and different people. So it's something that I've seen the consequences, the implications, if not managed well. And it's something that you can make a lot of changes by intervening early. So I'll spend the rest of the morning telling you a little bit about one of my patients who I saw actually about 2-3 weeks ago. I'll share his story to sort of give an idea and bring to life all the things I'm going to discuss with you, with all of you this morning. I'll tell you what I think hypertension is, how common is it, what causes it, and what types of it do we have. What can you do to reduce your risk of getting hypertension? What happens if not diagnosed early or treated properly? So, and then we'll talk about what does that treatment look like? And at the end, what are you going to take away from this morning? What's the point of turning up today, and of what benefit is it going to be to you? So I'm going to share a case of this gentleman. He's 49 years old, self-employed, slightly obese and overweight. Actually, the technical definition of his weight is that he has got obesity. He was diagnosed with hypertension at the age of 40. He came for NHS health check. At the time, his cholesterol was 7.2. He smoked, and he had a family history of hypertension. So about 3 months ago, he attended A&E with slurred speech, a weakness in his left arm, and he was diagnosed as having TIA or mini stroke. So he went on to have a Doppler scan of his neck, a jelly scan of his neck, and it showed that one of the arteries that supplies blood, that carries blood from the neck to the head, it's mostly blocked. And only a small amount of blood was flowing through. He proceeded to have a surgery to remove that blockage. It was successful initially, but as with such risky procedure, he had a bleed. And he went back into theater and ended up on intensive care for about 1 week. And 3 months later, he came to see me about 2-3 weeks ago. He's recovered well physically, but psychologically he was still struggling. He was still off work, and when I spoke to his wife, the impact that this had on his wife was quite immense, as well as to my patient. So, for something that started off, benign, in quote, or without any symptom, to lead to all this complication, it has quite a devastating impact on an individual, not just them, their family. The guy is self-employed. What happens to his finances, to his mortgage? What if he was the breadwinner for his family? So there's a lot there. But can I just wanted to ask you a question. There is an offer here, okay, of opportunity to win a blood pressure machine. But you can't be, I want to ask you a question. I know it's medical, but I'll explain why at the end. Can anyone type in the chat the first person to type in the chat 2 risk factors that this gentleman had that may have led to him having that stroke. The first person to type in 2 risk factors will win a blood pressure machine. I'm told that it will be organized. So Diana, I can't see the charts. Please, if you can tell me when people have typed into it. So I'm going to pause for about a minute.
Quincy, thank you. We would monitor that. And also just to add in to our respected and able viewers, there are actually 5 blood pressure monitors going. It can't get better than this. So Dr. Chuka will, through the program, keep you engaged with questions, and also in the Q&A session, we'll be able to sort of ask a few more questions. Everything will be put into a draw and 5 people will be chosen. So Dr. Chuka has already said he's going to give away one for the first 2 people. So we do have two comments in the chat, and
what
I
are they
can
saying?
see Ngozi said cholesterol.
Fantastic.
And DA said lifestyle, cholesterol and obesity. So those are the first 2 that I could see, but please, the chat is open to everyone. Oh, sorry. I think I missed the top ones. I'm sorry. So Ernest, I think Ernest was the first. He put in salt and cigarettes. And then someone else put in obesity. So yeah, the race is certainly on. Did you say the first 2 people then?
Well, we can amend it. I'll leave you to run that competition. But the first people, I just wanted us to engage.
Yeah.
To see how much people are following. So that's fine. I'll leave you to decide who wins and who doesn't. But the point is, I just wanted us to take a look at the gentleman, and then that will lead me into discussing what is hypertension. Okay. So when we talk about hypertension, we talk about, can you all see my cursor?
Yes, we can.
Yeah, great. So when we talk about hypertension, we need to talk about what does blood pressure mean. What is the systolic blood pressure and diastolic? What do they mean? So if you look here, you can see the blood pressure machine. There's always a top number, always high. It's called the systolic blood pressure, and there's the bottom one called the diastolic blood pressure. What do they mean? It's quite simply saying that they're measuring your the pressure of blood that flows through your arm. Now, where does that blood come from? So when our heart is a muscle. So when it squeezes, it pumps blood out under high pressure. That top pressure is called the systolic blood pressure, because it measures the pressure generated by the heart when it's contracting. In medical terms, we call it systolic phase. When the heart is relaxing, it's called diastolic phase, the blood pressure falls. So what the blood pressure machine does, it simply tells you what is the blood pressure around the artery when the heart squeezes and when the heart relaxes. That's what it is. So that's what the top bit is, and that's what the bottom bit is. So the reason I've created this table is sort of to illustrate the point that blood pressure is a continuum. It's not a black and white thing. So you check your blood pressure now, 2 minutes later, you check it again, you get a different reading. So when we talk about normal blood pressure and you come to your GP or your pharmacist, have it checked, and it shows 140, the top one, and or less than 90, and less than 90, the bottom one, that means you have a normal blood pressure. So systolic BP of 140 or less, or 90 and 90 or less of diastolic pressure, they are classed as normal blood pressure. Now, if for any reason, when your blood pressure has been checked at that point, it shows up between 140, the systolic is between 140 and 180, then you may have hypertension. If your diastolic is between 90 and 120, you may have hypertension, okay? Now, at that point, your GP will say, okay, I need to check whether you have hypertension or not. They will do this in one of 2 ways. They will either ask you to go and buy a blood pressure machine, or they will loan you one, and they will ask you to do your blood pressure reading twice a day, morning and evening, and bring the results to them. The other thing they could do is to refer you to the hospital for what we call 24-hour blood pressure monitoring. Some practices may have the equipment for this. So you come in to the hospital or to your GP practice, they'll put the machine on, and you go home, and the machine will do your blood pressure overnight, and you return the machine back to your doctor. If the average reading of this measurement comes back to be anything equal to or more than systolic pressure of 135 or more, or the diastolic pressure is 85 or more, then then your doctor will diagnose you as having hypertension. If when they do your blood pressure in clinic and it's more than 180, the top one is more than 180, and the bottom one is more than 120, then your doctor would diagnose you as having hypertension at that point, and we'll discuss the possible treatment. How common is hypertension? So we're talking about 1 in 4 adults in UK will have hypertension or do have hypertension. Most people are not aware of this because hypertension doesn't cause symptoms unless it's too high. So we know that in Black Afro-Caribbean of African descent, it's 3 to 4 times more likely compared to Caucasians when you look at the UK statistics. And also we are 2 times more likely to have stroke as well. Now, you wonder why I've got Trump. Trump made an announcement this week that he's launched a superhero doll of himself. I thought it was funny. I don't know why I included it, but it might be because of what I'm about to say next. So when you look at the types and causes of hypertension, they're classed into 2 types. There's what we call essential hypertension, and which consists of most people that will have hypertension. So there's what we call the non-modifiable risk factors. So this hypertension tends to be caused, some it might run in the family, some it might be due to ethnicity, like Black, Asian. This tend to be higher in that ethnic group. There's some theory including that we are more sensitive to salt, or also as you get older, as the older you get, the higher your risk of developing hypertension. Now, they included socioeconomic factors into the non-modifiable risk factor. And to me, actually, it is modifiable. Politics can make a lot of difference in poverty, education. So with the right policies, I'm not so sure that this can be classed as a non-modifiable risk factor. But anyway, it probably what led me to put the Trump post. I'm not sure, but anyway, moving on. So there's the key aspect is really that you can do so much to reduce your risk of having hypertension. Like the people in the chat said, obesity, being overweight, reducing your weight will reduce your risk. Stopping smoking, exercising more, and reducing the amount of alcohol and salt in our food makes a huge difference in preventing hypertension. A fraction of people with hypertension can happen because of other medical problems with their hearts, their kidneys, and I'm not really going to go into that much this time around. But what the focus of the talk today is on essential hypertension. If I may take a second, because of this is CAHN, and I thought it was important to bring up the racial disparities in diagnosing of hypertension in the Black and ethnic minority groups, and also in the treatment and outcome of treatment of hypertension and outcome for patients with hypertension in this group. So there's significant inequalities. Yes, there's genetic element, there's the social element. There's also aspect about our ability to respond to the medications available. Whether there's a genetic component there, I don't know. There's also the behavior, the fact that we're often too busy. We have relatives and uncles and people that we are taking care of, and you feel you have to work all the time. You don't have time to go and see your doctor and get your blood pressure checked. And you may not take your medication as often or have the time to pick up your medication and take it as often as you need to. So all those things add to it. There's also the medical element where the risk factors that we use as doctors to decide who we should start medication on tend to, it doesn't quite predict, it's not very good in the ethnic minority group, probably because when they did the research and did the data, there wasn't a lot of inclusion in there. So a lot is happening now because it's well recognized, and they're looking for quite very culturally specific drugs that they can manufacture that can help, and they're looking at how they collect data on ethnicity as well. So there's a lot of things. So moving on to the next question is, how do you reduce your risk of hypertension? I've talked about this before, about the lifestyle, lifestyle is huge. It makes a huge difference. But I thought I mentioned salt intake because it's a very important aspect of hypertension and cause of hypertension, even in managing hypertension as well. We know we are a lot more sensitive to salt. The recommended daily salt intake is about 6 grams per day, less than 6 grams per day. If you take on average day, you go to work, you buy sandwich, you chuck in some crisp to it. A serving of sandwich contains on half of what your daily allowance of salt already. You add the salt contained in this in the crisp, you find out that you already exceed, getting towards your daily allowance. Now we have all kinds of food, so it's important to limit anything that says pickled food, brine, smoked. It contains a lot of salt. So when you do your shopping, keep in mind that this is what's happening. Just 1 second. Yeah, I'm sorry about that. So and also there's this suggestion that sea salt, rock salt, or garlic salt, they're all different, but the truth is they're all equally bad. Or the other dietary advice include that it's also, some people add salt to vegetable, to pasta and rice. It's advisable to try and avoid this. So I've talked a bit about exercise. We're talking about 30 minutes of brisk walk, something that gets your heart rate pounding 5 days a week. Smoking, it says what it is, and that applies to alcohol. So now what happens if you have hypertension and it's not picked up early or treated? So you can see one of the first things, it can lead to kidney failure, and from there on the patient can go on dialysis. It also affects the eye and lead to what we call retinopathy and damage to the retina, which also can lead to visual loss. Then through this process called atherosclerosis, which I'll explain a little bit more. The bottom line is it's an aging process that happens to everybody. We have these open arteries as we are young, but as we get older, for several reasons or risk factors I'm going to talk about next, including hypertension, cholesterol, and so many other things gets filtered into the wall of the arteries and begin to block it. And eventually, if it's blocked, it leads to several things, including if the blockage occurs in the artery that supplies to the leg, then it leads to a condition called peripheral vascular disease. and patient might come in and complain of pain in their calf when they're walking. If it affects blood supply to the brain, it can lead to stroke, mini stroke, or dementia. If it affects the heart, and this is the important bit, because there are two aspects of the heart. If you look here where my cursor is, you can see blood supply to the heart muscle itself. So these are called coronary arteries. If they're blocked, and due to this narrowing here, it leads to what we call heart attack. And if you have heart attack, it can also lead to heart failure. But on the other hand, the heart it's a muscle. So imagine going to the gym and working out, carrying heavy, doing heavy lifting. Your muscles get bigger. The same thing applies to the heart. So once you develop hypertension and is not well controlled, what happens is the heart begins to pump harder and harder and work harder. Over time, it gets floppy, it gets bigger, and this condition called cardiomyopathy, which just means the heart structure is not doing what it's supposed to do. That also can lead to heart failure. So you can begin to see that hypertension, in addition to diabetes, high cholesterol, obesity, exercise, lack of exercise, they all contribute to this process called atherosclerosis, all resulting in narrowing of blood supply to many aspects of the heart. It can also lead to erectile dysfunction if it affects blood supply towards the penis. So there's huge complication that happens with undiagnosed hypertension or poorly treated hypertension. So this is the atherosclerosis process. I thought I'd make it a bit larger. So it doesn't really matter. We're all gonna have it, but nature has made it that it will happen about the age of 80, 90, or when we are older. But lifestyle, like people in the chat have mentioned, makes a huge difference to people getting this at a much younger age. For my patient to have a stroke at the age of 49, that's quite young. So what's happened there is that this process of this plaque formation here has happened because of his high cholesterol, his hypertension, family history of hypertension. All of that has led to changes in the wall of the artery, making it easy for things to get through, for cholesterol to get through, for platelets to get through, all these things to get in there. And once they begin to pile up, if you find out there's a traffic through that motorway, and over time that traffic gets worse and worse. So you get hypertension as one of the risk factors. So all of this. So when we talk about cardiovascular risk, we're talking about things that cause this process called atherosclerosis. Hypertension is one of them. High cholesterol contributes to it. Diabetes has a role. Smoking has a role. Chronic kidney disease plays a part too. Being overweight and obesity. So you can see, other than genetics and your age, most of the other risk factors, you can do so much about them. So you also notice the same thing that increases your risk of hypertension also increases your risk of developing this atherosclerosis that could cause dementia, stroke, and kidney problem, and all the rest of it. So how is hypertension treated? Like I said before, lifestyle is the cornerstone of it all. So it's not just that lifestyle changes reduces your risk of getting hypertension. It also reduces your risk, or it also helps treat hypertension and lowers your blood pressure. So you can do a lot to lower your blood pressure beyond having medication. But at the same time, the lifestyle has a big impact, but the medication also has an impact. So when you combine lifestyle and medication, the impact is much bigger. So most people will need both to manage it. So one together, they work a lot better. Now, I'm going to briefly give you an overview of what the drugs are. So the drugs, there's a lot of drugs to be used. So there's the ACE inhibitors, yeah, that will end in pril. Their name will have something pril on it. There's the angiotensin receptor blockers. They will have a SATA, losartan, valsartan. There'll be a lot of them. And these are the alpha blockers. So we use the ABCD way of naming or categorizing these drugs. It doesn't really matter much how they work, but the bottom line is some of them relax the arteries and the blood vessels and lower blood pressure that way. Some of them increase the heart rate or reduce the heart rate, and that also lowers the blood pressure. So it doesn't really matter. Some of them may have some side effects, but they're usually mild, and some people get used to it after the first week. If it becomes a long-term problem, go back to your doctor, and they will change it to tons of. There's so many drugs that could be used. So if your body doesn't, if you don't tolerate one, go back. You might tolerate the other one. There's another category called spironolactone that I've not included there. So there's all kinds of medication that can be used. The key thing here the key message for me that I wanted to get across is that each of these drugs will reduce your blood pressure by about 20 millimeters of mercury, by 20 points, okay? So you'll find out that people with hypertension may need 1 or 2 medication, maybe sometimes 3 tablets in order to control their blood pressure. My experience as a GP often is a conversation I have with my patient. They will say to me, well, I'm well, I'm healthy. Why should I be taking medication? I'm not ill, I'm not poorly, you know? And I can understand that, because what we're talking about here is prevention. So you are looking at a category of people who are well, and you're trying to keep them healthy. So I often will go back and go, okay, I hear you, but yes, you don't like taking medication. But actually, if you take 2 medications now, that can prevent you from taking 10, 12, 15 medication if you have a heart attack. So there's a lot of conversation to be had. It's not easy to get people to take their medications every day. So understanding what hypertension is, how it fits on in the context of everything, and being open, listening to any concern of side effects, anything like that, makes a huge difference, okay? So it's really important to keep that in mind. And my patient brings all of this home. And it was just listening to what his wife said to me, you know, that she was so scared, she was so frightening. She described it as a trauma for her, watching her husband go through what he went through, you know. So it sort of reminds me quite often why I do what I do, that it does matter. So this is on the left here, you have 1 or 2 tablets that you can take. That can versus prevent you to having to take that many if you have a heart attack or develop heart failure. So in essence, what are the key points here that I'm hoping that you're all going to take away today? Hypertension. It's important to know if you have it or not, because if you do, there's so much you can do to change the trajectory of your life, for your family, everything. We know that the modifiable risk factors, it takes a bit of willpower, really, although it's not easy, but it makes a huge difference. If you can make subtle changes, you know, as you saw in that stack, the more of the risk factors you take up that stack, the lower your cardiovascular risk becomes. If we don't treat hypertension, it has dire consequences. Lifestyle matters so much. It is important to find out if you have hypertension. And again, I'm repeating it again. They say you repeat it 3 times, to stress it. So lifestyle works, medication works. This is not about conspiracy theories, not pandemic or COVID vaccine. This is evidence-based. It makes a huge difference. And you can see, I see the impact on a regular basis. So I'm going to end by talking about know your numbers. If you look at the flyer, I'm sure CAHN done a lot of promotion on know your numbers. So when I talk about know your numbers, it's not just about your blood pressure. It's about knowing what your cholesterol level is now, knowing what your HbA, what your go for diabetic checks. If you have diabetes, know what your HbA1c number is. Anybody over 40, up from 40 to 74 in this country, can go for NHS health check. It's done every 5 years. So every 5 years, from the age of 40, go to your GP and ask, please, can you have your NHS health check? And they will sort it out for you. If you have hypertension, most practices will invite you around your birthday. In fact, actually, I would change that. I'll flip that a little bit and say, around your birthday, know you need your annual check. You go and see your GP, make an appointment with the nurse or the healthcare assistant. What they will do is they'll check your blood pressure. They will organize blood tests that will that will assess your cholesterol level, check for diabetes, look for chronic kidney disease, and they will do this for you on annual basis. Because once you have hypertension, they need to keep an eye on your overall cardiovascular risk. So knowing your numbers, what is your blood pressure? You can go to your local pharmacist. Yeah, so you can go to your local pharmacist to have your blood pressure checked. So in summary, it's important to know your numbers. Whether you're well or you already have hypertension, it doesn't matter. Thank you very much.
Thank you very much. Thank you so much, Dr. Chuka. That was really good. Very, very sort of simplified, but very factual as well, and really breaking things down for us to understand. And all those pictures helped as well. I like one of the slides where you had, on the one side, just say one pill versus when someone has had a heart attack, all those medications that they need to take. And it's a common thing that we hear where people say, I'm taking so many medications. And as you've said, lifestyle is really important, and that would help us to modify a lot of those risk factors, which is where we can really make a change. That's where we can do something, and there's a lot that we can do. So thank you for that very insightful talk. And we go into our Q&A session. So there are lots of comments and questions coming up. Before we go through those, I just want to acknowledge and thank all those of you who've been posting your sort of comments in the box. And for those of you who haven't managed to, please feel free to do so. So with the contributions about the risk factors, Ernest, John, you made some submissions, Ngozi, DA, Kemzi, I think iPhone user, Beverly, Dr. Grace Maduka, Anthony Marriott, and all of you who've posted stuff in the chat box. Thanks for your contributions. All of those risk factors Dr. Chuka has also confirmed in his talk as well. Right, so as we go along, there will be feedback forms sent out, so please do help by completing those so that we can improve the services we bring you. And the first 2 blood pressure monitors are gone because I want Dr. Chuka's word to be believed and to be true. So he did say that the first 2 people will get it. So we'll give those first 2 to the first 2 who posted those.
We need to, and then we need to make sure they're not healthcare professionals. They have to be, they can't work for the They
can't, yeah, that's fair enough.
They can't be healthcare professionals. It's not fair.
It's not fair, yeah, it's got to go to the general public. So our digital assistants, can we screen that and make sure that it's not going to healthcare professionals or people who are from CATHIP or CAHN? Right, so there are still 3 monitors to be won. 3 monitors to be won. So as we go along, if there are opportunities to do so, be quick, be on it, and you can hopefully win something. The way it will happen is we'll put all the answers into a draw, and then the 3 people who win will be contacted, as we've done previously with the other draws. Anyway, so let's go on to the questions. Quincy, someone is asking, so Abena Maroon is asking, what can I do to minimize getting hypertension or high blood pressure? What other ways can I manage to lower my blood pressure without taking medication? So I think she wants to know, she doesn't, I mean, if you're not keen on taking medications, then what are your options really?
That's an interesting question. Okay. Look, every treatment of hypertension it's individualized. There's no one size fits all. So it depends on your overall risk. Do you have diabetes? Do you have high cholesterol? What's your family history? How old are you? We take all of that into account. So the treatment is bespoke to you. Okay, so that's number one. So it's very difficult for me to say whether or not you can or not. So if you have diabetes and your blood pressure is high, as I showed in that risk factor chart or bar chart, that it all adds up. So we need to control your blood pressure. In fact, your blood pressure target, if you have diabetes, is less than 130/80. So it's even much less for people who don't have that. So everything is tailor-made to each individual person. Now, other thing is, how high is your blood pressure? Okay. If your blood pressure, starting blood pressure is 180/120, doesn't matter the amount of lifestyle you make, unless, let me paraphrase. If you had a BMI of 44 and you had a bariatric surgery and your weight went from 140 kilograms to 70 kilograms, then fine, that can make a huge difference to you. But if your BMI is already maybe about 30, 32, 35, 33, you're not really going to lose that much weight to make a huge difference to your blood pressure. So lifestyle has a role to play, but is not instead of medication. Now, I'm doing some caveat here because NICE has made it a bit more confusing. They've talked about stage 1 hypertension, stage 2 hypertension, stage 3 hypertension. If you do that, what in practice, it doesn't work, because that person that you say it's stage 1 hypertension today, when you see them again in the annual health check, their blood pressure is now on, they're now on stage 3. So it's not practical. So from my point of view, experience point of view, lifestyle, it's so important, but you need to, medication has a huge role to play too. So I'm not advocating one over another. I advocate both, because the lifestyle not just reduces your blood pressure, it lowers your overall risk of developing stroke, heart disease, dementia, all of it. So lifestyle has a big role to play, but in combination with medication, and it all depends on your overall risk factor. So I don't know if I've answered your question, but that's the best I can offer.
That's very clear. And Benny, I'm sure that really would help. And I agree with what you're saying, Dr. Chuka, that, both things work. And if you're on medication, you shouldn't stop doing your lifestyle measures. And if you are, doing those lifestyle changes, you shouldn't stop taking your medications if you have been prescribed, because clearly at the point of you being prescribed medications, it's because it was felt that you needed the medication. So certainly the two will go hand in hand. So please, I hope that helps. And maybe your best chance of avoiding medications is probably nipping it in the bud when it's at the stage where, lifestyle only would make a difference. But I think once you go past that point, you're really looking at considering being compliant with your medications. And if you've got concerns, then speak to your GP. But thank you so much for that, Dr. Chuka. So Ernest would like to know which of these drugs could cause problems with maintaining erection. So quite an important one for the men: erectile dysfunction and blood pressure medications. You're not escaping that one. Come on, tell us.
Yeah. Honestly, okay. It's a very important question. Okay. I'll go a step further. It's actually the even important reason not to do what you can to avoid getting hypertension in the first place. Okay. So that'll be the first step. Avoid getting it. Change your lifestyle. Look at what you do when you go lunchtime, what you buy at the co-op or M&S or whatever you shop, or Aldi, wherever you shop. Look at the packets and look at the salt intake. So that will be the first part to the question, or answer to the question. Now, the drugs that cause, and secondly, if you develop those narrowing in your artery and it affects blood supply to the penis, you're also going to get erectile dysfunction too. So when somebody has an erectile dysfunction and they come and see me as a GP, I see it as a cardiovascular risk. So there are two aspects that I look at. I look at the cardiovascular risk of the patient, and I look at what are the psychological impacts to that man. So we look at both things, but the cardiovascular risk, it's telling me if there's a problem with the blood flow to the penis, it's probably happening in the blood flow to the heart, to the brain. So that's why we look at it as a cardiovascular risk factor. Now, when it comes to the individual medication, everybody's different. Okay, the blockers tend to be a lot more known for it, but all the other ones less so. Amlodipine doesn't usually. Occasionally, some people will say that the diuretic ones may, but even if you come under the diuretic ones, there are some that don't do it at all, and there are some that may occasionally do it. So, to answer your question, which ones? I would say beta blockers mostly, but all the others should be fine. And even if you come to the same group, there are other ones that you can try that may not cause it. So the take home from my point of view is, if you have any side effect, go back to your GP straight away and say, I have this side effect. And they have lots of other options to try. Okay? And if your blood pressure is not controlled, then you may also get erectile dysfunction. So if you say, I'm not going to take the drug because I've got an erectile dysfunction, then invariably your arteries are going to narrow and you're going to get erectile dysfunction. So you're better off going back to your GP to help if there's any side effect.
Thank you. Can the team backstage check the noise, please, and see if we can mute? I think someone might not be aware that they are coming through. Thank you for that, Dr. Chuka. So Ernest, and for all our men on the call, let's try and prevent hypertension where we can, if we're concerned about erectile dysfunction, because the hypertension itself can actually erectile dysfunction. Right, so that was a very interesting one, wasn't it? And then Samsung SM user, there's no name, says, I'm taking Ramipril and amlodipine to lower my blood pressure. So that's really good. If you're on those medications, keep taking them. And thanks for sharing your experience. Sandra says, I've experienced hair loss while on amlodipine. Shall I ask for a different medication? Should people be asking for something different if they're getting side effects, if they're having things they think might be due to the medications?
The answer is yes, but there's always a but to these things. Hair loss, it depends on how bad we're talking about. If it's that your hair is falling off a little bit, it's different from when you're having bald patch. Not as bad as mine, but good big chunky bald patches. Now, hair loss happens for so many reasons, but we find out that the trigger for hair loss is because something has happened to accelerate the growth phase of your hair. So new hairs are coming out and they're pushing out the old hair. So you will find out that when people have hair loss, you will see new hairs coming out. So quite often, by the time you notice the hair loss, whatever triggered it has come and gone. And and what you think is the reason, probably not the reason of what triggered it in the first place. Okay, so when it comes to hair loss, it's unusual that the medications cause hair loss. It's quite unusual. But if you feel, for the whole point in taking medication is your belief. If my patient belief is that it's the medication, I would change it. Because if it's not addressed and is there niggling in the patient's mind, then they're not going to take the medication. So from my point of view, if anything is going to make you not to take your medication, let's just address it straight away. Okay, so if you feel that that's what it is, by all means, let your doctor know there's all kinds of options there. Some people may get some ankle swelling, bit of ankle swelling with amlodipine, particularly if they go up to 10 milligrams of amlodipine. At 5 milligrams, it doesn't happen very often, but some might do. It tends to be more important to women. You know, maybe they have to wear their high heel shoes. I'm sure they're like, I don't know. The man, not so much. This is just experience, not just talking about practical experience. No chauvinism here, just saying it like it is. But anyway, just for the feminists or anything, I'm just saying this is just the practical terms. But on a more serious note, so amlodipine can cause a bit of ankle swelling. If it does, you can stop it. Your GP can, if they add something like a diuretic to it, that will reduce the risk of you developing ankle swelling. So you can still take the amlodipine. So there's a lot of permutation there that your doctor can play with, you know. But coming back to the hair loss thing, it's your health belief that matters. If you believe that amlodipine is causing it, tell your doctor, they will change it for you. But it's unlikely due to amlodipine.
Thank you for that. And it is quite interesting when you talk about the belief system, it really influences patients' compliance a lot, isn't it? And even our response to medication. So absolutely spot on. If we are concerned about something, please let's discuss it. I had a patient who hadn't been taking their statins for ages, and we kept prescribing it. He was collecting it. They were piling it up, not taking it. And when we did their blood test later, we found out that their cholesterol was way higher than even, before the statins were prescribed. And then he opened up and said, oh, I've not been taking it. And it turned out because he believed that whatever he was experiencing was because of his statins. And time again, when it'd been asked, are you taking your medications? Yes, absolutely, I'm taking it. It wasn't until someone actually took the time to say, what's going on here? He came clean and said, this is what it is. So it's absolutely important that if we're worried about something, we must discuss it, that we can have alternatives. I think, thankfully, Dr. Chuka, with antihypertensives, we do have quite a few options, don't we?
Oh, lots.
It's one of those areas where we're fortunate to have quite a few options. So,
yeah.
Right. So Claude would like to know, if your lifestyle fails and you start taking medication, can you stop once the hypertension is back to normal, as long as you keep your lifestyle? So I'm still on lifestyle, but my reading is 138/80 to 145/100. So that's what Claude is saying. What's your thoughts on that?
Claude, very fair question. Again, it depends on your overall risk. That's number one. The second thing is this: our blood pressure, the bottom one being over 100, concerns me. If you were my patient, we're going to have a one-to-one conversation and say, look, lifestyle is good. You have to continue it. Okay. But the medication, even at 100, I'll probably add another medication to what you're taking. Okay. Now, consider a car. If you have a car and you put it, say, let's go back to manual days, manual car. These days, everybody drive automatic. But let's just, okay, in manual days, okay? So you do your clutch, you do your gear, and you put your foot on the brake, okay? Because you don't want the car to move forward. You have your foot on the brake, okay? What happens if you take your foot off the brake and put the accelerator on? The car moves. So the brake is what's stopping the car from moving. Yeah. So that's the same thing as the medication that you have in treating hypertension. The medication act as a brake. If you take that brake off, that blood pressure will go up. Okay, so lifestyle will have an impact, but it won't have an impact. So if your blood pressure is just marginally up, it might make a big difference. But if your blood pressure is 150, 160, 170, what are we doing? So again, everybody's different. And the way I'm going to have that conversation with somebody who's got diabetes and people who's got chronic kidney disease or other comorbidities will be quite different to a 40-year-old who's just been diagnosed with high blood pressure. Everybody's different. It's all on the age, risk profile. There's so many things that come into it. So the answer I'm giving you, it's like flying blind, okay? Because there's so much more that needed to be taken into account. But in summary, medication is a brake. You take your foot off the brake, the car moves. That's what happens with hypertension.
Thank you. And a very nice analogy about the car. It got me thinking about those days. I don't know whether you ever experienced this or saw this, where if someone's car couldn't start and then they had a few people to push it and you go to the top of the hill and then they push you and then suddenly when it goes and you're going down the hill and you're in free flow and then the car is just going. Yeah, so clearly if we don't sort of tackle it properly, then it's that sort of slippery slope as well. So thanks for that, Dr. Chuka, and hopefully that answers your question as well. Now, let's move on swiftly. So Sandra says, my daughter is only 28 and her blood pressure is extremely high, so 150/100, and they've started her on medications and they've said perhaps she's just prone. So that's Sandra's comment. I'm wondering what the actual question is, but I suspect what she's trying to say is it just because she's prone? Could this be something more genetic for her to be having, high blood pressure at such an age of just 28, quite a young age for getting blood pressure? Or could there be more going on? And then I'll just tie that with a second question for you, just because we've got quite a few questions in the box.
Okay.
If your memory can hold the first one, I'll add the second one. Does intermittent fasting and daily exercise help? So that's from Ebony. So let's tackle Sandra's 28-year-old daughter first, and then we'll come to Ebony's.
Yeah. Sandra, I'm sorry to hear that your daughter's got hypertension at 28. Every clinician is different. I don't know what they've done already, but what I would do is what I'm going to share with you. Okay. So in somebody under the age of 40, if they develop hypertension, we need to know why. There has to be a reason. Okay. You need to look for it. Okay. So even the NICE guidelines tells us as GPs, we need to refer for specialist assessment to exclude a secondary cause of hypertension. So if you remember in my slide, I talked about other things, diseases affecting the kidneys, the heart, and the endocrine or the hormones of the body that can cause hypertension. So that needs to be looked into. I appreciate that these days people are getting overweight at a much younger age, and if you're obese, it can increase your risk quite high. But that is not an excuse not to investigate and look for other causes of this. So what we normally do is we'll do battery of tests, including cortisol and blood different tests to look for to exclude common secondary causes of hypertension. Then you refer the person on to a heart specialist, a cardiologist. The cardiologist will do a couple of things. They will get an echocardiogram, an ultrasound scan a jelly scan of the heart to look at the structure of the heart, how big it is there anything around the heart that may be causing this? They also refer for what they call an angiogram. So they look at the blood flow to the kidneys and a few other areas. So they will do certain things there to make sure there's no other reason why the person has developed hypertension at such a young age. Okay, so so there's a bit of the hormone test that needs to be done. If GPs can't do that, then they should refer to an endocrinologist, which is a hormone specialist who can do all those tests. So a 28-year-old with hypertension should be treated aggressively. It should be looked at, is there any reason why? Their blood pressure target has to be less than 130/80 all the time. So the way I would manage their hypertension will be completely different from the way I manage the hypertension of somebody who's in their 70s and their 80s. So I don't know whether she's seen a heart specialist or not, Sandra, but yes, it definitely is worth it. Now, second question, whether intermittent fasting works. Intermittent fasting helps people lose weight. And if you're losing weight, it definitely has a huge benefit, as we can see the risk factors for hypertension and cardiovascular disease. So it has a role. Some people often combine it with low carb type diet and all that. Those are great things to do. But is that alone, is it okay? Is that if your blood pressure is too high, would that be enough? I'm not so sure, like I talked about in my answer to previous questions. So again, it's individualized. If your blood pressure is really, really high, I don't think there's an amount of intermittent fasting that you're going to do that's going to get you out of it. Mm-hmm. Okay, so it all depends on individual circumstance, and having that conversation with your GP will make that difference to address all these questions. So I don't know if I've answered it all, but yeah, Sandra, sorry once again.
Thank you for that. And yes, indeed, Sandra, our thoughts with your daughter, and we hope she gets the right care that she needs. And Abani, I hope that helps as well with the intermittent fasting answer. Now, can I just crave the indulgence of our listeners and our audience? It's 3 minutes past 12, and there's still quite a few questions. So I think we might end up going over the 12:15, if that's fine with you, and if that's okay with you, Dr. Chuka. So that we can quickly address these questions. Remember, there's also a chance to win some blood pressure monitor. So, Doc, if you wanted to throw any questions as well, or any teasers, that would be
they all seem to be experts. I was going to ask again about the cardiovascular risk factors, but everybody seems to be experts now. So there's no point. It's not. It's
I'm afraid it's the CATHIP audience. They're well educated. So yes. Okay. So Claude says, if you're doing exercise and your blood pressure goes up to your pulse rate, I think he wants to say, goes up to 160 or more. Is this good or bad? Or are you putting more stress on your heart to, pump oxygen and blood around the body? So basically, is it a bad thing to work your heart up to a pulse rate of about 160? And then Pat and Lucas Nape from Rafa posed a question saying, do oily foods help? Do limiting oily foods help with improving high blood pressure? So one along the sort of lifestyle lines.
Yeah.
So let's have those
two. Did you know? Why am I the only one answering these questions? You are here with me.
I know. It's just because you're the one in the hot seat. So
okay,
you're the special guest for today.
It's okay. So now, right, the first question. Remind me again. It's
yeah. So if you sort of work up and your heart rate goes to about 160, is that a bad thing for your heart? Yes. Are you putting too much stress?
Okay, so this is the thing. Okay, so actually, if we think about the body's response when we exercise, is to increase blood flow to all the muscles, because when you exercise and the muscles are working hard, they need more blood supply. So how would your body get more blood supply to the muscles, to your thigh muscles, to your arms or whatever? What it needs to do is it will increase your heart rate. It will increase your blood pressure. It will do all that. So that is those things are normal response to exercise. So that's okay. That's what you would expect to happen when people are exercising. So so in short answer, because I know we have a lot of questions, that's the normal response to exercising. Okay.
Yeah.
Now, oily fish. I'm not a dietitian. Okay, I'm just gonna throw that out there. I'm definitely not a dietitian. I don't know what type of oil fish is it. Does it contain brine? Is it smoked oily fish? Is it? I don't know. It's a very broad question. This one. Okay.
Sorry, oily foods, not fish.
Sorry. Oh, oily food.
That's even broader than just the fish.
So yeah. So the point is, if you talk about oily, we're talking about saturated fats and unsaturated fats. So it's looking at what that oily fish is and how much of saturated, because saturated fat, they're bad for you. Unsaturated fats are good for you. So you need to look at what it is that you're looking at, and that will help with that. So I hope I'm trying to be faster, quicker, so we can get through more questions.
Thank you. So I think it's back to what Dr. Chuka has been saying, that our diets, lowering our cholesterol levels and our lifestyle makes a massive difference. So if we can watch what we're eating, then that would certainly make a difference. I think there's another question along a similar theme, which will probably tie in with what you've said already, Dr. Chuka. So Samsung SM says, I've reduced adding salt in the food as a majority of foods contain high level of salt. I now have substituted salt for herbs. So that's really good. And I think it ties in.
Can I comment on that?
Yeah.
Can I comment? I thought that's really brilliant, actually, because rather than using salt, you can use herbs and spices and other forms of natural way to add flavor to your food. So it's quite a sensible approach to take. Well done.
Well done, yes. And I think it's important that we enjoy the food we eat, because we derive a lot of pleasure from eating. So if you know that you want your food to be tasty, to be seasoned, then find the healthier alternatives and still make your food tasty, but cutting out those risk factors. So that's really, really commendable. Jenny McLaren has sent us a message from one of our callers. I have high blood pressure, but occasionally take amlodipine. But can this cause problems like darkening of the skin and internal bleeding? So quite a loaded question, but I'm sure you've got a lot to say about this. So this person has high blood pressure and they occasionally take amlodipine.
I don't know why you're sounding so like a GP. It's quite funny, your reaction to occasionally. Look.
Yeah. So obviously a lot to explore and try and help this caller, isn't it? Yes. So please, over to you.
Yeah. So look, first of all, I think what that is saying is blood pressure medication shouldn't be taken occasionally. You need to take them every day. You're meant to take it because the part of the problem why high blood pressure damages the blood vessel is the spike, up and down spike of blood pressure. That's what causes the problem. So if you're not taking it every day, the days you're not taking it, it shoots up. The day you take it, it goes down. The day you have it, it goes up. So those are the things that actually cause damage to the blood vessels and begin to cause that to hasten and quicken that atherosclerotic process. So it's important to take them regularly every day. So that's to get that first part out of the way. Amlodipine, it's unusual. The way it works, it just relaxes the blood vessels, the muscles around the blood vessels, and opens them up. It doesn't affect the skin per se, so it doesn't really darken the skin. I'm not sure what it can do to melanocytes of this the thing that gives us the dark skin color. I'm not sure. I haven't come across it before, and it definitely doesn't cause internal bleeding at all. Okay, there's no mechanism. It doesn't affect the things that protect the lining of our stomach. It has nothing to do with it. Amlodipine can cause ankle swelling, like I said before. When you start taking them the first few days, you might get a bit of facial flushing because it opens up blood vessels around the face and all that, which settles quite quickly. But beyond all those common things, those side effects are pretty unusual. Okay, but you raised a very important question. We should all take our medications, blood pressure medication, every day.
Thank you. And Jenny, look, thank you so much for this question, because I think it just highlights the fact that sometimes we think that we can take our blood pressure medications as and when, or, maybe when we check our blood pressure and it's high, and the days when we check and it's not so bad, we can skip it. But I think you've raised a really important point, which maybe a lot more people are experiencing, but you're the one who's posted your question. So thanks for that. We're really grateful for that question. We should be taking our blood pressure medications every day. And secondly, again, back to what we were saying about, and what Dr. Chuka said about, a patient's beliefs. So if you believe that your amlodipine might cause your darkening of skin and internal bleeding, it might be the reason why you've not been taking it. So really, as Dr. Chuka said, go and see your GP, have a conversation, get that elephant out of the room, address what your concerns are, and let them put you onto something that you're happy with. But clearly, we have no evidence that amlodipine would cause darkening of the skin or internal bleeding. But really, thanks for bringing that up, because I'm sure that's really a real life situation there that you've shared.
Absolutely. And it's the essence of today's conversation, really. Yeah. Because for me, it's essence. How do we, because we say that we don't comply with medication very, very well, but these are part of the reason, because of what we believe is happening. And having a conversation with your GP is crucial, and being open to have this dialogue. That's why I love being a GP.
Fulfilling, despite all the pressures. We'll keep our head up and keep smiling. So Sandra Moody says, yes, I've been having swellings too. I didn't realize it could happen with this. I've been taking amlodipine for 7 years now, but only 5 milligrams, but I get swollen ankles. Yeah. So Sandra, same advice. And they can give you alternatives.
Can I contribute?
Yes, in a minute. I was just gonna okay, you come in, because I was gonna let people come in at a point, but you come on that one, please, briefly.
Dr. Diane, I'm on I'm ledopen.
Yeah.
And Ramapur. But it's giving me issue on my ankle. It has given me ankle swollen. And when I complained it to my GP, he said amlodipine is good for the Black community. But yes, still I'm having that issue. It's making me discomfort. You understand? So I don't know what to do. But they gave me a gel to apply on it, but nothing is, to be precise with you, working. And sometimes I feel some sharp pain, and I have to stand for a while before moving.
Yeah. Wow. Sandra, sorry.
Thank you. Wow. Was that Ruby?
Yes, Ruby? Yes, Dr. Diane.
Okay, Ruby. All right. Thank you so much, Ruby, for your comment, and tying that in with the comment that Sandra has also mentioned. So yeah, Dr. Chuka, over to you. But thank you for that comment, Ruby, and we are sorry to hear that you're really struggling.
Yeah, Ruby. Yeah, sorry. I mean, I think it highlights the issue, the point that we're making all morning, that because there's no point. Remember, what we're dealing with is risk factor, something that can potentially cause a problem. Now you're taking a medication that's making your life miserable. I'm sorry, those two doesn't quite equate, okay? Because this is your now. That's more important than what may or may not happen. So I think there's a lot of option here for your doctor to tap into. Yes, there's this thinking that actually that we as Blacks don't produce enough ACE inhibitors to work, the drugs like Ramipril, okay? But actually there's a new research saying that's not really the case these days. And there's a push to change all the national guidelines to move away from that mindset, okay? So that's number one. Two, the immediate thing that your doctor could do is they can take away the Ramipril and put you on a diuretic called, one of them called indapamide. It's a water tablet. So what it will do is that will get rid of any water retention in your leg and sort of counteract that side effect of amlodipine. If that doesn't work, then your doctor can stop the Ramipril and stop the amlodipine and leave you on the indapamide and Ramipril. So there's so many permutations that can happen, but I know I've mentioned a lot of drugs. I don't want to confuse you. Okay? But your doctor should know this. It's about going back, and either if the doctor doesn't want to do it, you can find another doctor in that practice and move things around. But the bottom line is you can go back and ask, can you have can you change the ramipril to a water tablet for blood pressure? And
Okay.
that could be a simple way of dealing with it immediately.
Okay, thank you so much. I'll do that on Monday.
I like that, Vim. Thank you. Thank you so much. God bless you all. Right.
Thank you,
So
Dr. Diane.
you're welcome. And thanks for following us very closely all the time. So I think there's a hand raised. So what I would say is, because of our time, if you've got any further questions, please email them to health@cahn.org.uk, and we'll try to move them on to Dr. Chuka to kindly answer, and then we can bring the response back to you. We'll go through the questions that are in the chat box now, and then we'll try and bring the program to a close at some point. It's a very interesting, stimulating discussion. We did warn Dr. Chuka that this topic is quite an interactive one that people are always very interested in. So, Dr. Chuka, we hope you don't mind us taking a few more minutes of your time.
No, it's fine. I'm here. I'm here. Whatever you need me to answer, I'm good. I've got my cup of water. I'm ready. I'm good to go.
Thank you so much, John. Was it John or James? Would you want to unmute yourself? I think you had your hand up to ask a question, and can we be brief as well, please? Thank you.
Hi. My name is Grace.
Oh, Grace.
Initially, there was a question about garlic that I want some clarity on, because there was a slide that said reduce salt and also garlic. Now, from my understanding, garlic's supposed to be good for high blood pressure. So can you clarify more? So is garlic good for high blood pressure or not, Dr. Chuka?
Thank you.
Grace, you don't need to sound formal to me, man. Come on, really? How are you?
I'm fine.
You for joining.
You're doing a good job. Thank you.
Okay, let me correct what I said in the slide. So the slide is not. I'm not saying that garlic is bad at all. I'm talking about garlic salt, rock salt, all those different named salt that they try to market as, oh yeah, it's safe. It doesn't. That's all it does and doesn't do. I have no idea, so I won't claim to know. But what I'm talking about is garlic salt, rock salt, and the rest of other salts.
Thank you.
Is that okay?
Yeah, thank you.
Grace, cool. We'll speak later.
Thank you, Grace, for that. That was good. Thank you. So Dr. Chuka D says, I have heard that drinking lemon water can help reduce hypertension. Is that correct? Krista says, what causes plaque formation in the arteries and how can one manage high cholesterol? So two sort of different questions, but just putting those together. So if you've got any brief comments on those, thank you.
Right, lemon water. I don't know. That's the honest answer. I'm definitely not I'm saying this again. I'm not a dietitian at all. There's a limit to what I know as a GP. I'm sure if you Google, do lemon water, look for reputable sites to read your information, like published articles. You might find a bit more information from reputable sites, not from everything on the internet, because some dodgy stuff on the internet. So we need to be careful where we get our advice from. I will always recommend, when you do your search, type in NHS next to it, so that you get NHS type response to your question. So that will be a good place to start. So I don't know about lemon juice. I've got that one is beyond me, and I can't answer. Sorry, I don't have an answer for that one. So the second question is from
Krista about plaque formation in the arteries and how can one manage high cholesterol. So I'm sure you can give a whole talk on that, but just the condensed form, please.
No, it's okay. It depends on what time they join. So it's I'm happy to answer this. Like I said to you before, plaque formation happens for so many reasons. Age, genetics, you can't do much about those. Obesity, hypertension, smoking, diabetes, high cholesterol, they, one way or another, affect the walls, the lining of the arteries. And once the lining begin to get damaged, more cholesterol get deposited behind the wall, and that gradually closes, begins to close up the artery. That's the process called atherosclerosis. It's a lot more complicated than that, but I've just kept it as simple, as basic as possible to convey what happens. So once you have that plaque formed, then you get traffic and slowing of blood flow, and then eventually blockage, and then things happen. So things that will lower your cholesterol are the things we've talked about in terms of lifestyle, exercise, avoiding saturated fats. There's evidence suggesting actually that high carbohydrate food might actually increase your cholesterol. So it's much conflicting these days. So I'll go balanced diet, okay? Bit of high protein, some bit of fat there, unsaturated fat mostly, small amounts of carbohydrate, plenty of exercise, and a sprinkle of herbs and garlic and whatever works for you. That's it.
Recipe done. Thank you. And also, just to add to that, Dr. Chuka had one of his slides, and you had a really lovely slide on that plaque formation where you explained it in details. So these sessions are recorded and they are on YouTube. So please do feel free to go back and listen when you have a chance to. And he's clearly really explained that in lovely simplified detail about how plaques can be formed. But thanks for your question, Krista. And Elsie says, should I be measuring my own blood pressure and how often? I'm 62. And Ruth says, is coconut oil good to take? So I guess it probably will be similar to your answer about the previous ones, but anyway, and Grace has already talked about her garlic. And do you want another one, or is that enough for now?
Let's do one actually.
Let's do one at a time. Okay. So Elsie's question: should I be measuring my own blood pressure and how often? I'm 62.
Hi, Elsie. Thank you for the question. Again, it comes back to individual circumstance. So if somebody's got high blood pressure already, then measuring your blood pressure, for me, it's quite empowering, and I'll encourage people to do it, particularly if you have hypertension. If you've not got hypertension, that's a different thing altogether. So if you have hypertension already and you're in treatment, then I'll probably say do it maybe once every 3 months, or thereabouts. So we don't want you getting obsessed with it and people doing it every day. No, because it's just going to go up and it's just going to make yourself very stressed and anxious. No, it doesn't help anybody. So I'll probably say once every 3 months, have your blood pressure checked. Once every 6 months, it's more than enough. And then you go to your GP for the annual review in between. So that would be my answer. Yeah, in terms of coconut water,
can you add beetroot to the coconut oil one?
I don't know. Sorry, I can't answer that. I'm not a dietitian. I'm definitely not a herbalist. No, the ones I can answer, I can tell you straight away. These ones I don't know. Sorry.
And that's absolutely fine, because as he said, as GPs, it doesn't mean that you know every single thing about every single food group. So we do have our Healthy Heart sessions on Tuesdays, and we have nutritionists and dietitians who take us through all these things. They go into so much more detail, and that is really their comfort zone, and they will be able to answer. But please send these questions to health@CAHN.org.uk, and then we can get one of the dietitians to answer it properly, give you all the evidence base, and email it back to you. Thank you. So one last question for you, Dr. Chuka. What makes, Keddy says, what makes someone have bags under the eyes or swelling under the eyes? He or she's on ramipril and amlodipine. So what could be causing bags under the eyes? Thank you. So swelling.
Bags under the eye. it's it's genetic. It's part of aging process. Some people are prone to it, and most of the time has nothing to do with the drugs. It's not the same swelling that we're talking about that happens with amlodipine in terms of ankle swelling. Bags under the eye, if you've had a long night, you've partied too much, it's more prominent than if you've been well rested. So in terms of bags under the eye, yeah, it's not medication. It's multifactorial, and there's no I don't know of any link or association with the drugs used in treating hypertension, and definitely not amlodipine. So it's one of those things that happens. Yeah, I hope I've answered the question.
Yeah, thank you so much for that. Okay, and probably maybe a bit more information is needed, so please speak to your GP to see if there can be a bit more history taken to work out what's going on. But no, thank you so much for that, Dr. Chuka. Is there anyone who has
Dr.
wanted to
Diana,
unmute themselves? Was there anyone? I think there was someone briefly. If we can take that last comment and then we'll be wrapping up. Yes, please carry on.
Dr. Dan, can high blood pressure affect the eye?
Can high blood pressure affect the eye? Okay, thank you for that. We'll come to that question. And was there anyone else who wanted to quickly unmute and ask their question? One last question.
I think it was just me, Dr. Asante. I was just going to mention or ask Dr. Chuka if he had any opinions on the use of kind of concentrated beetroot juice and the nitrate concentrate. I know that kind of from a sports background, it's incredible, it's amazing, kind of stuff. It loads and reduces people's kind of figures quite considerably within a really short space of time. I just wondered briefly if he had any comments on that, kind of concentrated beetroot or nitrate juice.
Right, thanks James for that. So thank you everyone for the questions and for unmuting yourself and for putting your stuff in the chat box as well. Any comments on those two? Sorry, we keep coming to the same thing. Sorry, Dr. Chuka, but any comments on those two submissions, please?
Sorry, I needed to unmute myself. Yes, absolutely. I was trying to get the name of the lady that asked the first question. It doesn't show up. It was
Ruby, I think. It was Ruby. Who asked the first
okay. All right, Ruby. Yes. The hypertension can affect the eye. I think I showed it in my diagram where I showed the complications if we don't pick up hypertension early, and if it's not treated well, that it can affect the eye. We call it hypertensive retinopathy, which simply means that the retina at the back of the eye that helps us form the images, the blood vessels to it get affected, and they become leaky, and the whole place, there's a bit of scar tissue around it, and it may begin to lead to visual loss. So yes, blood pressure does affect the eye. So hence why we're having this session to make sure that if you have high blood pressure, that you make the appropriate lifestyle change, and that you take medications regularly as prescribed by your doctor. So yes, it does affect the eye.
Thank you very much.
Okay, thanks, Ruby. And but James, I think I need to have something on my forehead saying I'm not a dietitian. I genuinely don't know, James.
I totally put you on the spot.
Yeah, I don't know about the beetroot. This is all way. Yeah, I think what Diana said in terms of when the event with the dietitian and nutritionist will be perfect to answer all these questions, and it would be good if you can attend to get the answers. Thank you.
Thank you so much. Look, Dr. Quincy, Chuka, you've been great. You've absolutely answered most of our questions and addressed things in a very practical way for us. And we're so grateful for your time this morning. Thanks to every single person as well who's commented, who's contributed, who's answered questions, who's asked questions. What we'll do to make it fair is we're putting everyone into a draw, and then we'll do the draw, and the 3 people who win the blood pressure machine will win it. Because I think it's such a clever audience. There's no way we're going to ask questions and be able to fairly distribute the 3 remaining blood pressure monitors. So we're rounding up now. Massive thanks to Dr. Chuka, who's taken his time to go through this session, and massive thanks to everyone. Thank you for sticking with us throughout the year 2022. It's been a great year by God's grace. I know we've had ups and downs, we've had our own challenges, but hopefully we've been able to have a productive year. We've been able to empower ourselves, enrich ourselves, and it's been so much better with you along the journey with us. We appreciate all our sponsors, all our partners, all our collaborators, all our presenters who've taken time out week in, week out to come and present, and all our hosts as well who've joined hosting the program. Thanks to Dr. Ngozi, thanks to Dr. Vanessa, and everyone else who's given their time to making these sessions great. Do stick with us, don't go away. I'll hand over to James to do the closing for us, so that we have the rest of the announcements, know what's coming up, and also know how we can go about winning our blood pressure monitors. Thank you. Over to you.
Thank you, Dr. Asante. And yeah, just once again, just to reiterate all of the thanks that we have to make, that we have to kind of pass on from all of the CAHN team that work behind the scenes, but particularly kind of the people that make these sessions possible every week. It's kind of they've been amazing, covered such a breadth and depth of kind of topics over the year, and we're so grateful to everybody, all of the contributors and all of the presenters. So on behalf of all of the CAHN team, thank you so much for that. It really is. It's been an amazing year. Let's hope we can carry on and build some momentum for next year as well. So, Angela, if you would be able to put up the first slide, please. We want to give you a final, kind of recap of some of the events that are coming up in the next week. So, on Monday, we have the opportunity for some people, to go along to the Pendleton Gateway and to get their health checked by our nurses and some of our health professionals. It's on Monday, the 19th of December. The time is from 10 till 1:30, and the venue is Pendleton Gateway, and that's Broadwalk in Salford. So if you've got the opportunity to get down there, have a quick health check, then that's available for you. And thanks to the nurses and the CAHN team for doing that. The next thing to mention is the end of year Christmas event for our Wigan focus group. This takes place on Sunday, the 18th of December, and it's 3 to 6 o'clock. There's a code, a dress code for that one that is obviously going to be the hilarious kind of Christmas jumper competition that everybody seems to get involved with. So if you want to come along, please do get involved with that. Location is Sunshine House in Wigan. It's on Wellington Street. And yeah, the more people that we can get down there, the more that would be great, and we look forward to seeing people there if at all possible. Next slide, please, Angela. Excuse me, sorry. So don't forget, we understand that kind of things are tough at the moment in terms of the cost of living and the extra pressures that the season kind of brings. So we just want to make sure that we remind everybody that we're still here. Despite it being the holiday season, our team is still here, ready to help and support you. We have the family the advocacy, domestic violence and support services. And of course, it's just a telephone call away. The telephone number is 077 10 022 382. Our staff and team are always there, ready to be able to help and support people, point them in the right direction, be it around kind of general advocacy or even counselling support. So please do, kind of make, kind of avail yourself of that service. The email for that service is help@cahn.org.uk. I did want to point out as well, just to take the opportunity whilst I've got everybody here, that we're raising money for the advocacy and domestic violence service at the moment. So please do keep your eye out for a crowdfunding campaign that starts on Monday the 19th. That campaign will run for 6 weeks, and we've got the aim of raising an extra £20,000 for the service. We're very lucky in being supported by Aviva Insurance and Crowdfunder to be able to double the value of any donations that are made across that campaign. So please do, if you consider giving this year, please do consider CAHN and the advocacy and domestic violence services as a recipient of that gift. Like I said, the extra bonuses, that we have some match funding from our colleagues at Aviva Insurance. So thanks for that. Next slide, please, Angela. Like I say, whilst it is the holiday season, our colleagues are always there. My colleague Lande is always available. Her telephone number is 07385 608328. So reach out, please, if you need any, if you have any questions about the health hours or need any connections to do with some of the things that you've seen today. Please do. Big shout out to our one of our partners, Enfield Caribbean Association. Dion is the contact there with telephone number 07958 230 923. And of course, RAFA, International Development Agency, telephone number 0121 358 2231. Please get in touch with them if you want to contact them. The Royal Assembly Redeemed Church, Christian Church of God, Dr. Samuel is the contact there. His telephone number is 07882 931 539. And of course, we have our colleagues at Croydon BME Forum. As you can see, the telephone number for their contact to contact them is 0208 excuse me again 684 37119. And finally, big thanks to our colleagues at Black Health Initiative. Telephone number 0113 307 0300. And that's it really from us for this year. But yeah, just once again, just to reiterate our thanks to Dr. Chuka today and Dr. Asante from everybody and the whole team at CAHN. We hope you have a very happy holiday season. Stay safe and well, and we look forward to reconnecting with you in the new year. Thanks,
and thank you. Sorry to come in quickly. Next year, when we resume our health hours, we will announce the winners for the blood pressure machines. So please do stay tuned. Join us in the new year, and we'll contact the winners of the draw. Merry Christmas to everyone. Have a wonderful festive season. And thank you so much to the CAHN and CATHIP team behind the scenes. You've been brilliant this year. Bye, everyone.
Welcome to our Caribbean and African Targeted Health Improvement Program, CATHIP Health Hour. The Caribbean and African Health Network, CAHN, along with its national partners, are incredibly pleased to continue to bring to you targeted health and well-being education delivered by Caribbean and African doctors. These health hours are all about empowering, educating, and giving space to Black people so our communities can look after themselves better. Every Saturday, our Black GPs or consultants present on those health and well-being topics that affect you, your family members, and friends. Some weeks will vary and will include other panel members such as pharmacists, specialist nurses, and faith leaders. Our health hours cover a range of topics and include mental health, heart health, women's health, reproductive and sexual health issues, men's health, respiratory problems, cancer, sickle cell, and many more. We have not forgotten to include within our health hours the many societal, cultural, religious, and racial challenges that can go hand in hand with health problems and influence how we should respond to meet health and well-being needs. The sessions are designed for you, and we want you to use the time to listen, learn, share your experiences, and ask questions to our Black doctors. During every session, we will gather your feedback so we can continue to respond to the needs of our Black community. To request any particular topic, please email health@cahn.org.uk. We encourage you to invite others to our health hour sessions. Spread the word in our community. CATHIP is funded by the National Lottery Community Fund.